Welcome to the Reinventing the White Coat podcast, where we delve into conversations aimed at helping you foster a healthy relationship with your career and yourself. If you're a physician feeling unfulfilled or burned out or want to prevent yourself from going down that path, then this podcast is for you. I'm your host, Jennifer Scher, pediatrician, chief wellness officer, and executive and life coach. Sit back and relax as we explore ways to live your best life and have a career in medicine. Today I have Dr. Andrea Austin. Andrea is a board-certified emergency physician, a coach, and an educator. She writes, teaches, and researches how we can create more change makers in healthcare. She coaches healthcare professionals and works with organizations to go upstream to fix the issues that cause burnout. And most recently, she published a book called Revitalized, a guidebook to following your healing heartline. Andrea, thank you so much for joining me.
Oh, it's such a joy to be here. Thank you for this opportunity, Jennifer.
So, Andrea, I actually just read your book. And normally I ask people, it's funny because, and just for full disclosure, Andrea and I met each other through a coach training that we were in. And so we knew each other sort of, but when I read your book, I suddenly feel like I know you a lot better than you know me. It's this lopsided. But for the rest of the listeners, maybe you can share your journey a little bit and what got you here.
Yeah. So I grew up in Iowa in a very, very small town, and I didn't really have a lot of exposure to different career paths. Everyone that I knew was either, a police officer, a teacher, a doctor. And I decided that I wanted to go into medicine. I got to shadow a physician assistant in my hometown. I was really kind of taken up into medicine, how it blended science and talking to patients. And somewhere along the way, I got interested in the military, and I ended up joining the military to pay for medical school. And that certainly guaranteed that I was going to leave Iowa. There are no Navy bases in Iowa. There's seas of corn, but no seas of ocean. So I ended up in San Diego and I did my residency there. And again, when I thought about being a doctor, I thought I would just see patients. I didn't really understand all the different things that could happen with your career once you become a physician. And unfortunately, I did experience episodes of burnout. And I say unfortunately, but when now I look back on that last episode of burnout, I really feel like it was a gift, because the career that I have now wouldn't have happened without that, really dark time in which I had to get clear on my values, boundaries, and priorities, and craft the career I have now, which involves honestly like less patient care, more doing simulation. I direct a lab. I also direct a simulation certificate program for the military. And
What
yeah,
is
do some
that? Can you
coaching.
describe what that
Yeah.
is?
Yep. The certificate program,
Just a simulation lab. I
simulation
mean,
in
I think,
general.
yeah.
Yeah. Yeah. So medical simulation is, one aspect of it is training and education. So the simulation lab I have at Southwest serves a healthcare system and our primary users are residents and fellows. So helping them learn procedures, clinical reasoning. And so there's mannequins, and then there can also be standardized participants, which are actors that portray different scenarios.
Mm-hmm.
And then there can be a translational component in which we do some simulations in the hospital to work on safety, quality, process improvement, which is an area I really, really enjoy. And then with the certificate program for the military, that's a formal 1-year program that people can get advanced training in how to be a simulation teacher. So it's a little meta there. So I teach people how to use simulation as an educational modality, and also about the administrative side, because there's a lot of things to know about running a lab.
I think when I was in med school, right? I'm trying to think if it was med school residency. No, in med school, I was at Mount Sinai, and they were one of the first places to do Mount Sinai in New York. I know there are multiple Mount Sinai's, but they were one of the first places to do those little actor, observe. Oh, it was so awkward and uncomfortable for me, but that I guess was the beginning of sort of simulation. I think about that episode of Seinfeld. You remember when Kramer was like a patient?
I
Anyway,
do. Yeah. Yeah, it's a good one.
anyway, I remember being in there and I just was not the type of person to feel comfortable being it was not a real reflection
Mhm.
of what happens to me when with the patient because I'm very comfortable with the patient, but when the camera was on and the judging, I was so awkward. And I remember being in there and I thought I had nailed the case. I knew one was going to be psych and one was going to be surgery and one was going to be and one of the cases, it was clearly like a depressed person. He was like, I'm so tired and I'm this. I'm like, okay, he's depressed. Let's move on to the next room. And in the next room was someone who was floridly psychotic. So I was like, uh-oh, what was that last guy? He clearly was not depressed. I messed that one up. And he was a new onset diabetic. He was just tired and like down and I pigeonholed myself because I knew that this simulation was artificially, one's going to be surgical and one's going to be psych and one's pediatric. I'm not sure why I shared that, but that was my experience with simulation. Do they still do all those live labs like when we did that dog lab with the physiology? I mean, it was such horror show, like pushing Lasix and then massaging the heart. And do you know if they still do stuff like that?
And so what you're describing was I think what we would call a vivarium, so with animals.
Yeah.
Yep. So I don't participate in anything like that. Essentially that's becoming almost a thing of the past.
Good.
So yeah,
Yeah.
we certainly don't use any of it at Southwest Healthcare. I think there's a lot of issues around the ethics of that. So I would say most people that are simulationists, that's not really anything that we do.
Yeah. And now with AI, I imagine this is going to just take off.
Yeah, yeah, it's fun. So it's really the blending of technology to, I think everybody can relate to at this day and age, it's not acceptable for healthcare professionals to be learning how to do their skills on actual patients. And
Right.
it's really not acceptable to learn on animals either, in my opinion. But certainly not to be learning on patients and the technology, the mannequins, and then, standardized participants. It sounds like listening to your scenario, there was a couple things going on. So there was the Hawthorne effect of you being watched.
Right.
And then two, what was the psychological safety around that? Because it sounds like what you're describing is you didn't feel you were worried about getting judged. It didn't feel
Correct.
very psychologically safe.
Right.
So the good news is we've made a lot of improvements on that.
That's great. I'll have to go through it again someday. So, Andrea, over the course of your career, and it's funny you say somehow I ended up in the military. That's not something I can imagine as somehow happening with, without some really clear planning and thinking. But I know, and after reading your book, I really know that you've been through some pretty toxic, stressful situations. And, you know, within a place of safety here for you to only share what you would like to share, I thought maybe you could at least give a little something of how that has sort of informed the path that you've traveled.
Yeah, I think I was very unprepared for how psychologically unsafe much of medicine is. I went into it with a lot of altruism. I certainly looked up to everybody that was a physician assistant or associate or, physician in my community. So when things started to happen in medical school or residency that, involved bias, discrimination, it really took me aback. And then I think the second thing that happened was the gaslighting. And, I can think back to my residency. It was a very male dominated program. There were lots of good people and there was a lot of good experiences, but there was some, blatant sexism that occurred. And then when I would try to bring that up, there were people that diminished my experience. And that's gaslighting. And
Mm-hmm.
it took me a really long time to reconcile all of that. That how could this happen in, a profession like medicine? I still kind of find it so bizarre that we're supposed to be taking care of patients and we have ethical principles. We take an oath when we
Yeah.
become physicians. And so when these unethical things happen, when we mistreat each other, it really took me a long time to figure out, how am I going to navigate that? How am I going to activate my agency to continue to practice a career that I gave up a lot to have? It's not fair for me to be pushed out of this, but how do I recraft my career to be fulfilling and to do it in a way in line with my ethics?
Yeah. You know, the term gaslighting, I don't even know. I don't know if it's a new term or if it's just become more known, but we didn't even have a word for that back then. I think that's part of the reason why we didn't talk about it because there was no language around it. It just was. But
Yeah,
let me
and that
ask,
was a big part of why I wrote the book. Is, I mean, gaslighting has been in the zeitgeist for probably the last 5 years.
hmm
But when I talk to physicians, they still don't know that term or really know how it applies in the medicine context.
mm. So when in your experience and advice that you share with people, when do you think people should consider the difference between, leaving a toxic workplace, and when it's so toxic versus optimizing and adapting yourself so that you're tougher, so to speak, and
Mm-hmm.
sort of stay in the game? Like, how can people know which one is better for them?
Yeah, it's a really complicated question and one that I think is best. I mean, if you're really struggling with it, I would highly recommend getting a coach to work through this. There are some published guidelines around like what is defined as toxicity. And there was an MIT Sloan article on this, and essentially workplaces that are discriminatory, workplaces with cutthroat, backstabbing culture. There's a few other criterion there. So what I like to think about is those type of behaviors can happen. And honestly, if you talk to anybody who works, nobody's workplace is perfect. The question is, when those behaviors happen, how do people respond to it?
Mhm.
And if those things are happening and, you speak up for yourself or somebody else speaks up, the response is really, for me, what defines whether it's a safe place for you to stay versus you should leave. The other thing I will say is always choose your health above an organization.
Yeah.
So if you're feeling at a point like, if I stay in this job, I don't think I can live.
Mhm.
Whether that means, you're contemplating or having like flashes of suicidality, or you're just feeling, I describe at one point in my book, I was getting chest pain and I was like, I can't do this. Like something is feeling like completely antithetical. Like I'm having a physical reaction
Yeah.
to this place. And, I think the other thing I would say is, if there's toxic things happening and you're not quite sure if this is like, maybe this is just one boss, maybe there's something that, can be fixed. Can you decrease your exposure while you're trying to sort that out? Can you go to part time? Can you go to per diem? Can you make some adjustments? For some of us, we work at multiple hospitals. If it's, one place that just isn't working for you, could you shift things? And that gets into something from coaching about limiting beliefs, because sometimes we think, oh, well, I can only continue at my job if I do it this way. Well, the truth is, healthcare right now is tough,
Mhm.
and places generally want to retain you. So there's one place that they scheduled all of us as 12-hour shifts. And I was talking with another doctor, and they're like, "Oh yeah, I hate working 12s." So I just told the place I'd only do 6 or 8s, and then they rewrote my schedule. Turned out I went in and asked for that accommodation, um, and they made it. They didn't
Yeah,
even care.
that is such a good point, Andrea. And you going back to the point you just made about if it's um, to decide what the response is. Sometimes we're so afraid to even ask or to bring it up because we're used to just being looked at as good soldiers and perfect and nice, and we don't want to make waves. But I will say, as a boss, I have been in the experience where people have quit without saying anything, and then when they tell us why after the fact, I'm like, well, we would have made that accommodation for you. Like, you know what I mean? As opposed to when we have an open dialogue with people and things exactly like you said, family issues, what we will make schedule adjustments to accommodate for life. So sometimes it doesn't work out, but there is a place for each individual to advocate for yourself. And you said at the beginning that you learned how to set boundaries and do some of those things. Um, that's not easy to do.
It's not easy to do. So we're actually programmed, especially as physicians, to not have boundaries. They were pretty much stripped away from us as medical students when you think back to the schedules that we get, and you don't really get to exert very much control over your life. And as attending physicians, you really do have choice. And it's hard because sometimes we're like, but I want to make X amount of money. I want to
Hmm.
live here. Well, yeah, those are all choices.
Hmm. Completely. And um, and there was something else that I'm just like triggered by something else that you said about the feeling. Okay, you noticed that you were having like physical symptoms, right? I think a
Yeah.
lot of times um, we're so focused on our thinking. We talk about when we're not doing well, we talk about traditional therapy and cognitive behavioral therapy and talking it out and stuff. But what you notice with the physical symptoms, that's right, that what we talk about is the bottom up type of feedback that you get. And I talked a little bit about that in your book, and I think that's something a lot of people don't know about. So I was wondering if you could expand a little bit on that for people.
Yeah, so I think most people listening will be familiar with talk therapy. At least, we see shows like Shrinking, one of my favorite shows on
Love.
Apple, uh, about therapy and this idea that you go and you talk things out and you try to get your mind quote right. And this is honestly a big part of coaching. We talk about mindset, right? So trying to control to some degree our thoughts. Um, on the other hand, what we're learning specifically about trauma, emotional trauma, is it is stored in our body as well. And that seems very, like, when physicians hear that, they're like, what do you possibly mean
Yeah.
by that? And it gets a bit complicated, but when we think about our vagus nerve goes from our brains to our bodies and back and forth. And so when we're talking about that, I feel something in my body. So if I'm having this negative thought that, this, I don't like working here, and I feel like I actually have moral injury and my heart hurts, that can be that's a real feeling that you have in your body. And what you find with a lot of physicians is they're very disembodied.
Hmm.
When you ask them, like, you're describing sadness right now. How does that feel in your body? They'll just kind of look back at you like, what do you mean? It's a
Yeah.
thought, it's in my head. But then, as you begin to become more connected with your body, you might say, well, I feel heavy. And it's different for every person. They might say, well, I feel it in my jaw, I feel it in my stomach. But the first, I think one of the first steps is you're trying to live this more wholehearted, integrated life is, how do I feel in my body? And use that as an early warning signal. once you key into it, then, even if you can't, like you were saying earlier, like maybe I don't know the term gaslighting, but you also know how that felt in your body. You know how
Mhm.
that dissonance feels like, where you're like brain scramble. What? No, this doesn't feel right. Um, and listening to that and following that.
Yeah, we always ask our patients, how is the pain on a scale of 1 to 10? And how is this? And what's that? We don't know for ourselves. We
Yep.
really don't. One of my favorite books or one of the first books I read on this topic, um, what was it called? How the Body Keeps, what is
The
it? How the
score,
Body Keeps, yes,
Bessel Vanderkopf. Yeah.
yes. If anyone's listening and wants to kind of dive into this topic, I highly recommend it. Do you have any others that you would recommend on this topic?
Oh gosh. So I mentioned a lot of different books at the end of each chapter.
Hmm.
One of the resources I recommend is Glennon Doyle's podcast, We Can Do Hard
Hmm.
Things. She talks a lot about embodiment. Even if you just Google the embodiment episodes, I
Hmm.
think that's a really good primer.
She's great too, for sure. Yeah. One of the other things that I'm remembering from your book was how you talked about the way we downplay the importance of what we do. We don't want to seem overly cocky or narcissistic, and so we kind of like downplayed, and especially for you as an ER doc, I imagine that shows up big.
Yeah.
Why is that important?
Yeah, I don't think we teach medical students and residents a healthy sense of ego. And one of my favorite books is, I think it's On Peak or Peak Performance. And it's written by a woman who does a lot of like athletic things. She's a adjunct professor for the military at the Army Academy. And she talks about Coach from Duke, Krzyzewski. I can never say
Okay.
his name, the very famous basketball coach
Okay.
from Duke. And his whole thing is about healthy ego. That if he doesn't want a player on his team that's just like, oh, well, I'm an okay basketball player,
Hmm.
you want somebody on your team that's like, no, pass me the ball and I'm going to get it in the hoop. And I think we need to have more of that in medicine in a healthy way. I mean, certainly there are stereotypes of the narcissistic doctor. And
Hmm.
I think many of us have met some of
Yeah.
those. Um, but there's also a lot of people that are meek, that really will let an administrator walk all over them. And we need a healthy ego of, no, I went to school a long time. I do know this. I
Mhm.
do know how to take care of patients, and I actually know how to do it in a good way. And it's not that I'm not open to feedback, but I'm also not going to shrink. And that comes back to that, Buddhist saying of don't um, soft heart, strong back. Brene
Yeah.
Brown uses don't puff up and don't shrink. And I love
Yeah.
that too. You don't need to overinflate yourself and be a narcissist, but you also don't need to be a wallflower and let people walk all over you.
Yeah. I would take this over to outside of medicine and over into personal life and the way it's so hard for us to just kind of take compliments in general, deflecting a compliment. One of my friends wasn't a patient or a client or anything like that. It was just a friend who was going through a really, really hard time. And the listening ear I gave and the support I gave, when she got to the other side of it, she said to me, how, like what like you really helped me. Like I was like on the edge. And I was like, oh, no, no, no. She literally stopped me and said, no, hear me, listen to me. You need to accept, like, had to stop me in my tracks. And like, and that little, like, it sunk in when she forced me to receive it. It was so powerful. We try to brush these things off, I
Mm-hmm.
think, because we feel like it's just who we are and what we're supposed to do and blah, blah. But it is meaningful. And making those connections, also think feeling that gratitude and those connections will help us get us through the challenging moments more. Would you
Totally.
agree?
Yeah, absolutely. We're so quick to any criticism that we take, hold on to that, all the good jobs, good saves. And honestly, we don't get that many in medicine.
Yeah.
Like as an attending, the feedback you typically get is only when you've missed something. It's only the M&M notification.
Yeah.
I have a story in the book of a cardiologist that gave me positive feedback, and I nearly started crying because it was such a beautiful thing that he did. And it just took me aback because that's
Oh,
not the normative thing that we
yeah.
experience.
Oh, I love that. So, Andrea, you call yourself a change maker in the book and in general. And I ask you if you could explain what you mean by that and um, see if it would resonate with others.
Yeah. So if you get into the change literature, the term they typically use is change agents, so somebody that makes change. A change maker is defined as a change agent that does change for societal good. And I really think that distinction is important, and especially at this moment in healthcare, because let me tell you, there's a lot of change agents walking around your hospital. And I
Mhm.
think we're familiar with some of these change agents are definitely not making things better for all of us in society. Change makers want to take great care of patients. I'm not saying that there's no room for profit entities in healthcare, but that can't be the only thing that's discussed. So
Right.
when we're making changes, the very first thing has to be, how is this going to affect the patients? And equal to that, how is this going to affect the healthcare professionals caring for those patients? And for me, that has really transformed the way I think about my career. Um, and it's given me a lot of optimism about, how can I continue to work in a field with all the challenges that healthcare has
So, what
today.
are you doing in that space? I know you still do ER shifts, but what are you doing in the change making space? And I love that distinction between change agent and change maker.
Yeah. So, what's really exciting is I'm finishing up my thesis for my master's in healthcare professions education, and I did a qualitative study of 15 change maker physicians, and so that paper will come out probably in the next year. We're in the process of submitting it to a journal right now, and what's exciting about that is we are explicitly describing these are the personal characteristics that physician change makers have. And then these are the organizational factors that support change makers.
Ooh.
So I'm really excited to get that paper out into the world. And then I anticipate my team and I will be doing some workshops at medical education conferences to hopefully increase the number of change makers. I would say as a simulation director, I am making change every day.
Hmm.
I get emails about this happened in the hospital. How can we use simulation to improve
Hmm.
our education, our operations, and that. And then lastly, as an emergency physician, there's a lot of problems in emergency medicine today. Our emergency department is supposed to be the safety net, and the safety net is frayed, very, very frayed at this point.
Sure.
And so I can only do so much on my shifts. What has given me a lot of solace and honestly is the antidote to the moral injury that I'm experiencing is being involved in collective agency through the American College of Emergency Physicians and through working, I'm the chair of the women's section, writing resolutions, talking to lawmakers. All the advocacy that we do is a very important form of collective agency. So one of the last things I want as we're winding down, I want people to think about is you can have individual agency. Like I decide, how I'm taking care of this patient in front of
Hmm.
me. But the problems, the dilemmas that we're facing in healthcare today, no one physician can fix them. And so the only way we're going to be able to fix these problems is through collective agency. And collective agency happens at the, organizational level. So I would encourage and challenge physicians who oftentimes, say they're too busy to be involved in their professional college or too busy to talk to lawmakers. Well, where has that left us? There aren't that many physicians in the United States. We're actually a pretty small minority, and we have an outsized impact on how healthcare happens in this country. So, as my friend Risa Lewis says, we need to use our voices.
Yeah, I could not agree with you more. Part of the problem with shifting your focus from, like you say, upstream, right? When you're not doing the direct patient care and you're moving upstream to work on these issues, you lose your identity as a doctor, and you even get judged by your colleagues like you're not seeing patients anymore. And this work is so critically important, and you can do both. But some people really should commit 100% to this. It will make life downstream so much better for everybody if we have some good change makers up at the high level.
Yes. And as my coach, Cherie Johnson, reminds me, none of this has to be set in stone. You can have periods of your career that you shift to doing, less clinical work and, add some back in later. We can get into this very fixed mindset sometimes.
Yes. So true. All right. Well, that's actually a really nice place, I think, to wind this down. Let me ask you if you have any last words or want to tell people here is a copy of your book I'll show for those
Oh,
who are,
yay.
which I love. It's called Revitalized. I highly recommend it. Where can people find it, Andrea?
So you can find it on Amazon. Also, if you want a more friendly option, Ingram Spark. And if you head to my website, andreaaustinmd.com, and click on the book page, there's links so you don't have to remember anything. So just go to my website.
All right. Well, thank you again for joining me, for sharing your journey and your change making and all of it.
Thank you, Jennifer.
That's all for this episode of Reinventing the White Coat. If you enjoyed this conversation, subscribe now so you don't miss an episode. If you're interested in coaching or in being a guest on the podcast, you can reach out to me online at sharecoaching.com. Thanks for listening, and don't be afraid to live your best life.